Good morning. This is Phil Wilson, the President and CEO of the Black AIDS Institute, and I want to welcome you to When We Know Better, We Do Better, the State of HIV/AIDS Science and Treatment Literacy in the HIV/AIDS Workforce Media Briefing. The late Maya Angelou said, "Do the best you can until you know better. Then, when you know better, do better." I can't think of a more appropriate quote or a more fitting messenger when I think of this moment in time in the trajectory of the HIV/AIDS epidemic in America. Nearly 35 years have passed since the HIV epidemic first recognized, and nearly 2 decades have gone by since highly active antiretroviral therapies, or HAART, emerged. Only 2 years ago, at the International AIDS Conference in Washington, D.C., scientists and activists, including myself, held the potential for ending the epidemic once and for all. We have the tools we need to end the epidemic in America. The scientific evidence is now clear. Or is it? This study by the Black AIDS Institute, in partnership with Janssen Therapeutics, the Latino Commission on AIDS, and the National Alliance of State and Territory AIDS Directors, NASDAD, Johns Hopkins University, and the CDC, reveal there may be a missing link. As you can see on this slide, we have the treatment cascade. The treatment cascade shows the work that is yet to be done in the AIDS epidemic. Roughly 82% of the estimated 1.15 Americans living with HIV have been diagnosed. Unfortunately, only 66% of folks living with HIV have been linked to care, and then the wheels fall off of the treatment cascade. Only 37% of the 1.15 million Americans living with HIV are retained in care, and sadly, less than 30% of those living with HIV are virally suppressed. We are not going to end the AIDS epidemic if only 30% of folks living with HIV and AIDS actually have optimal care or viral suppression. In the next slide, we'll look at the breakdown of the HIV survey. In this slide, we see that the survey was designed to analyze the level of HIV science and treatment literacy among the non-medical HIV/AIDS workforce in the United States in 3 areas: basic knowledge and terminology, treatment knowledge, and clinical knowledge. The data was collected between 2012 and 2014. In the next slide, we'll look at the objectives. The primary objective of the study is to assess the level of knowledge of HIV science and treatment literacy and familiarity and attitudes about biomedical interventions among the non-medical HIV workforce. In addition, the study hoped to gain insights into gender, sexual orientation, ethnicity, HIV status, level of education, and tenure in HIV field. During this media conference, we will focus on ethnicity, HIV status, level of education, and tenure of HIV in the field. On the next slide, we will look at the approach. A quantitative survey was developed to assess the level of HIV science and treatment knowledge. The survey was implemented in 4 waves. The first wave was held at the U.S. Conference on AIDS between September 30th and October 2nd, 2012. 643 respondents participated in that rollout. There was a national rollout from March to May of 2013, and 1,523 respondents participated in that rollout. There was a Spanish language rollout between October and December of 2013, where 33 respondents participated. And finally, there was a state rollout from June to September of 2014, where nearly 1,200 respondents participated, for a total of over 3,600 respondents. So this is a very large study. Continuing our analysis of the approach, the survey took approximately 15 minutes to complete on average. There were 26 knowledge questions in the study, and each respondent was given 60 seconds to answer the knowledge questions to assure that they were using just their knowledge and not using other resources. In the next slide, we will look at the respondent selection criteria. There were 6 criteria for respondent selection: 18 years or older, work in AIDS service organizations or state or local health departments or community-based organizations, and be non-medical personnel. That means no doctors, no nurses, no physician's assistants, and no nurse practitioners. Let's turn our attention to the findings. Overall, the level of knowledge of HIV science and treatment is quite low. The average HIV knowledge score is between 61% and 63%. The median score was only 64%. With a score below 70%, 67% get a D or lower if this was an academic setting. Only 4% of the respondents would have gotten an A grade, meaning 90% or more if this was an academic setting. I'd like to now turn to a breakdown of how the knowledge played out across the various areas that we looked at. As I said earlier, we looked at basic knowledge and terminology, treatment knowledge, and clinical and biomedical interventions. Scores were highest on average for basic knowledge and terminology questions, a 76%, and lowest for the question pertaining to clinical and biomedical interventions, basically a 45% to a 46%. So if we translate this into an academic setting, overall, on all the questions, the respondents got a D. On basic knowledge and terminology, if this was an academic setting, the score would be a C. And in treatment education, the score would have been an F. And finally, in clinical and biomedical interventions, with only a 45% to 46% competency, it would have been a resounding failure. 19% of the questions focused on clinical and biomedical interventions. 35% of the questions focused on treatment, and 46% of the questions focused on basic knowledge and terminology. In the next section, we're going to look at HIV knowledge and the score predictors of HIV knowledge. On average, Black and Hispanic respondents scored lower than white and other respondents on the HIV knowledge questions. Blacks scored between a 57% and a 59%, Hispanics scored between a 54% and a 59%, whites scored between a 67% and a 68%. So between the white scores and the Black and Latino scores, we showed either a 10% difference, or in the case of Latinos, a 13% difference in the knowledge level. Education and tenure in the HIV field are the most powerful indicators of HIV knowledge. The higher the level of education, the higher the HIV knowledge scores. There was a difference in knowledge based on tenure as well. What we saw that for the most part, there was a gap between folks who have been in the field for more than 15 years and others. If you think back to 15 years ago, that was the advent of HAART and the HIV cocktails. There are lots of programs in the field doing treatment education. There have not been such programs since that time, so we suspect that the difference in HIV knowledge based on tenure, particularly those who have been in the field for over 15 years, is because they were in the field the last time there was a major push to increase HIV science and literacy in the HIV workforce. The next slide shows us the difference between those who are living with HIV and those who are not. HIV-positive respondents scored higher than those who are HIV negative on average. Now let's look at some demographic factors. Respondents from communities with high HIV awareness score higher than those from communities with low awareness, regardless of the level of education or tenure, etc. Both Black and Hispanic scored markedly lower in the HIV knowledge questions. These effects are not due to lower levels of education or tenure or any other demographic or organizational differences. Since these ethnic, sexual orientation, and HIV status effects are large and they remain significant even when other demographic and organizational factors are statistically controlled, it appears that they are due to the knowledge base these respondents bring from membership in these community experiences with HIV. Being HIV positive would tend to raise one's knowledge of the virus through personal experience. When we look at the LGBT community, it has a longer history with HIV/AIDS. The level of awareness and base knowledge about HIV and AIDS may be higher for LGBT respondents. Now, if we look at the three communities where folks scored lower, now the Black community, the Hispanic community, and the South, all those communities, we see that awareness of HIV/AIDS has historically been lower and stigma higher in those three communities. The Black and Hispanic and the respondents from the South may be entering the HIV field with lower knowledge base to begin. I'd like to dig a little deeper and show you the differences based on regions. If you look at the Deep South, where the average score was 61% compared to the Midwest, where the average score is 66%, we see a 5-point difference between the highest region and the lowest region in the survey. When we looked at state differences, while North Carolina, Florida, Texas, and Georgia are below the average HIV knowledge scores, Maryland respondents have above average scores, and those from Alabama, Louisiana, and D.C. have scores that are close to the national average. This slide also shows you the top 5 states and the bottom 5 states. Ohio, Pennsylvania, and Missouri with scores between 69% and 68%, well above the average, were the top 3. And Florida, Georgia, and North Carolina, which were the bottom 3 states, were below, as you can see, the national average of between 61 and 63%. The following slide shows you the ranking of the 15 states where we had a large enough sample to analyze. As I said before, Ohio scored the highest of all the states. North Carolina scored the lowest, and you'll see that New York, Louisiana, Alabama, Arizona all scored roughly around the national average. The next slide shows a map of the United States to give you a clearer picture of the impact of knowledge in different regions of the country, particularly the South. If you look at Arkansas, Tennessee, North Carolina, Georgia, Florida, Mississippi, Alabama, Louisiana, you see where there are clusters, and Texas as well, you see where there's clusters of low HIV knowledge or lower than the national average. The entire national map, quite frankly, shows that everywhere we have lower knowledge. So let's turn our attention to the impact of familiarity and attitudes. Familiarity and attitudinal agreement go hand in hand with higher scores. So for those who were very familiar or very familiar with pre-exposure prophylaxis, for example, and treatment as prevention, they scored a full 9 points higher than those who were not familiar with pre-exposure prophylaxis and treatment as prevention. Interestingly, when it came to microbicides and vaccines, familiarity did not appear to dramatically impact knowledge. The other area is the belief in the efficacy or the belief in whether biomedical interventions work. And we found consistently that those who believed in biomedical interventions scored significantly higher than those who did not. For example, those who believe that PrEP can drastically reduce new HIV infections scored 9 points higher than those who did not. Those who believe that treatment as prevention could drastically reduce new HIV infections scored 11 points higher than those that did not. Those who believe that suppressing HIV viral load with antiretroviral treatment reduces the risk of transmitting HIV scored a full 21 points higher than those who did not. 66% competency versus 45% competency. And finally, when we looked at belief in your own knowledge and training, we also showed a difference in knowledge. So those who believe that they have proper knowledge and training to advocate for their community to use PrEP scored 8 points higher than those who did not. Those who believe that they have the proper knowledge and training to advocate on their community regarding treatment as prevention scored a full 9 points higher than those who did not. So a belief, there's a relationship between your belief in the efficacy of biomedical intervention and a relationship between those who felt that they had the knowledge they needed to advocate on PrEP or the knowledge they needed to advocate on treatment as prevention scored higher than those that did not. Now, if we turn our attention to the demographic information, looking first at gender, the sample was fairly equally divided by gender overall, with 51% of the respondents being female and 49% of the respondents being male. The next area I'd like to look at is what percentage, how the respondents fell out based on race. And the survey respondents were primarily white or African Americans, with 46% being white and 36% being African American. Let's look at the sexual orientation factor on the slide. Close to 70% of respondents identify as heterosexual. Actually, 68% identified as heterosexual and 25% identified as gay or lesbian. If we look at the education level of the respondents, what we find is that almost 3/4 of the respondents have at least a college degree, and nearly 40% of the respondents have a graduate degree. Next, let's look at the impact of HIV status. 82% of the respondents reported being HIV negative, 15% of the respondents reported being HIV positive, 2% of the respondents declined to state, and 1% of the respondents did not know their HIV status. So now, let's look at the organizational breakdown in the survey. The majority of the respondents of the survey work for AIDS service organizations. 45% work for AIDS service organizations. 34% worked for other community-based organizations, and 21% worked for local or state health departments. Finally, let's look at what people did in the field and their tenure in the field. About half of all participants in the survey worked either as prevention outreach workers or case managers or social workers. 23% worked as prevention and outreach workers, 21% worked as case managers or social workers, 15% were directors, executives, or managers, and 8% worked in administration. On the tenure question, on average, the respondents have worked in the HIV field for 9 years, as you will see on this slide. But there's marked variations in field tenure, with close to 1/4 of the participants being in the field for less than 3 years, and 1/3 of the participants being in the field for more than 10 years. Finally, let's go to recommendations. The Black AIDS Institute is recommending that further training is desperately needed and should focus on treatment and new biomedical interventions and how to culturally and competently do these trainings to the communities that are being served. We are making 4 major recommendations in this report. We're calling for a national movement to increase science and treatment knowledge to end the AIDS epidemic in America. To help end the AIDS epidemic in America, first we want to call for a major initiative a major initiative is needed to increase HIV science and treatment literacy among the non-medical HIV/AIDS workforce. Number two, we're calling for the development of clear set of core competency for workers in the HIV field. Number three, we're calling to establish a nationwide certification program for HIV/AIDS in the workforce. Number four, we're calling to require that HIV/AIDS workers pursue continuing education on HIV science and treatment issues. We need to focus and prioritize African Americans and Hispanic workers and workers in the South. The low level of awareness and stigma associated with HIV in the Black and Hispanic communities and in the South have an adverse impact on the knowledge level in those communities. Having HIV workers from these two communities that are trained and is absolutely essential. Paradoxically, it is the low level of HIV awareness and knowledge in these communities that make reaching these communities so important. Finally, when we look at the difference in HIV status and knowledge, greater representation of those with the virus might also help improve the level of knowledge in states with low scores. It would seem that having workers who are HIV positive would not only tend to increase the level of knowledge of the workforce in these states, but might also improve outreach more generally. Who better to reach out than those who have the virus themselves? No amount of biomedical interventions will matter at all. No amount of biomedical interventions will get us to the end of the AIDS epidemic if those who are responsible for using them do not understand them, believe in them, and know how to use them. This study shows that we are leaving our most valuable resource behind. We have a large infrastructure of passionate, committed, and capable people who are working on AIDS service in AIDS service organizations, community-based organizations, clinical settings, and health departments ready to get the job done. But they can't do it unless they have the familiarity, the knowledge, and the skills they need to use these tools effectively. Now let's look at what we're going to do with this survey next. The next slide shows you our national rollout plan between Friday, February 6th, and Wednesday, February 11th. The Black AIDS Institute will be doing a national mobilization in 10 cities. Those cities include on February 6th, Dallas, Fort Lauderdale, Baltimore, Atlanta, and Los Angeles. On Monday, February 9th, Houston, Kansas City, Charlotte, North Carolina, and Oakland, California. Wrapping up on Wednesday, February 11th, in Chicago, Illinois. And this slide shows you where all the sessions are and when those forums will happen. So now we'd like to thank you all for joining us on this call, and we'd like to open the lines for any questions. Well, as there does not appear to be any questions at this time.
I got one from John, actually.
Okay.
He asked if we will be using the hashtag #KnowBetterDoBetter. Yes, that will be our national kind of Twitter, social media hashtag for all of these events. Did you want to add anything to that, Phil?
No. Okay.
We have a question that just came in from Evelyn.
Yeah, I can't type as quickly as I could speak.
Okay, that's fine.
I wanted to know who will be assisting in the development of the core competencies for, workforce certification.
We'll recommend the development of a national consultation that would include policymakers, folks from health departments, folks who work in the HIV/AIDS space, folks who are living with HIV, and folks who are high risk negative, and to develop those core competencies in concert with all of those stakeholders. Initially reaching out to, and doing this in waves, initially reaching out to people who are living with HIV and high-risk negatives and state and local health departments.
Thank you. I think that one of the most, thank you for doing this. This is so important and critical to the work that we're doing, because it also indicates, and I think, I haven't read the whole report yet, but I believe that it does identify that, a lot of our workforce does not have an understanding of the critical role they play in, reducing new infection, and that's very disturbing.
And what's important to note that moving forward, the HIV/AIDS workforce will not play a lesser role. In fact, the HIV/AIDS workforce will play an increasingly important role, particularly given that with the advent of the Affordable Care Act, an increasing number of people with HIV will be receiving their HIV care from non-HIV specialists. And so the role of the health department and the role of community workers and the role of AIDS service organizations will be vitally important to keeping people into care and helping them understand why being virally suppressed is important. The other factor is that we have a whole new world with pre-exposure prophylaxis. And again, this is a vital role for AIDS educators, people who are working in HIV, to help high-risk negatives maneuver through high-impact prevention and to discern the appropriateness of pre-exposure prophylaxis for them, how to use it, and why it's also very important for them to adhere to those regimens during the period of time that they're on them.
Thank you, and I can assure you that Broward is committed to responding to this call of action.
Thank you very much.
We had one more question come in, and this is again from John. He asked, what is your personal story with dealing with AIDS?
Interesting. I think it is important for people on the call to know that I actually am a person living with HIV. I've been living with HIV for over 35 years now. I am alive and well because I have access to the appropriate care and treatment, and quite frankly because I have access to the information that helps me understand why my treatment is important. I actually am living proof of what can happen when people living with HIV have the love and support of family and friends and access to appropriate care and treatment that we need and deserve. I also would like to think that as a person living with HIV, I also demonstrate the importance that people living in HIV can play both in HIV treatment and educating the community about HIV prevention.
Awesome. Thank you for your answer, Phil. I think that was it. I don't see anyone's hands raised, and I don't see any questions in the question box. So if you want to close out.
Okay, so what's going to happen next is that all of you will receive from us our press release along with a draft embargo copy of the report. You'll also receive our national fact sheet. We also have local fact sheets for all of the cities that we will be visiting next week, where we'll be doing mobilization efforts. So we have fact sheets for Dallas, Broward County, Baltimore, Atlanta, Los Angeles, Houston, Kansas City, Oakland, Chicago, and Austin. And we also have state fact sheets as well for all of the states that those cities are in. And so if you like to receive a state fact sheet or one of the city fact sheets, we will get that to you. But right now, we will be sending you the press release, the report, and the national fact sheet. If you need any other assistance or you have any further questions, feel free to contact us at the Black AIDS Institute. Please send an email or to assistant@blackaids.org, assistant@blackaids.org, or contact the people who are listed on the press release if anyone from the media wants to arrange for an interview or to get a quote from someone or has any media questions. And so that's all we have for today. Again, thank you for participating in this call. You know, I strongly believe that we can know better, and we will know better, and we will do better. Maya Angelou also said, whoever you are, wherever you are, start there. HIV started one person at a time, and in some ways that's how we're going to end the AIDS epidemic. But we're only going to do that if we make sure that the HIV/AIDS workforce has the information, the knowledge, and the skills that they need to get the job done. We will not end this AIDS epidemic if we leave the non-medical workforce behind in the process. Thank you very much.